You brought up an important topic. Let's just get into it. It's a good segue. So there was the CLL 14 data, the German CLL study group data that was presented at ASCO. It's been published now. We've seen it at meetings such here as Lugano. It's really examining that whole question of time-limited therapy. This being a study where patients with comorbidities or decreased renal function were randomized to receive obinutuzumab and chlorambucil versus venetoclax and obinutuzumab, and really impressive deep MRD negative states in the patients who were randomized to the venetoclax arm. So what's your take on that data? I mean, I'm very impressed by it.
Yeah, this is a very important study. So previously and in our discussion here, we've been talking about this dichotomy where we have to choose between time-limited chemotherapy-based approaches or novel agent-based approaches where we have to do continuous therapy. So this regimen, venetoclax plus obinutuzumab, is sort of the best of both worlds. It's novel agent only and it's time-limited. All the patients were given 1 year total of therapy, 6 months of the combination of ven-obin, and then 6 months of venetoclax, and then all patients stopped therapy. And certainly we saw very high response rates, around 85%, about half of patients achieving complete remission. There were bone marrow MRD rates of around 57%, I think, and peripheral blood even higher than that. And that was in an intent to treat analysis where a lot of samples were missed, so actually the true rate of MRD was probably even higher than that. And so, this is really an important study because it gives a new option for frontline therapy for our CLL patients that's time-limited and novel agent-based. Unfortunately, this study doesn't compare to ibrutinib, and so that remains the open question of which strategy is better, and now we have IV also, and so there's still a lot of unanswered questions. But I think this is certainly a very nice first step, CLL14, toward developing novel agent-based time-limited therapy. And I think the key is that is this going to be a durable enough response? If you do a year of time-limited therapy and 6 months later everyone's progressing, that's not really going to be feasible. So the follow-up remains relatively short on CLL14. It's a 28-month median follow-up time right now. What I think's been impressive so far is that at that mark, at the median time, about 88% of patients are still progression-free, and that's a year or more after stopping therapy. So there does really seem to be some durability of this time-limited therapy, particularly for those patients who don't have deletion 17p or TP53 mutation. Unfortunately, we have started to see some progression events for those high-risk patients already, which is a little bit worrisome that probably 1 year of time-limited therapy with ven-obin is probably not going to be sufficient for those patients.
Yeah, there was a lot of discussion in the meeting about what that subgroup, that specific subgroup. Now, thankfully, it's only 5 to 10% of patients in the frontline setting, and so that, but more follow-up is going to be needed for sure. John, has this changed your discussion with patients? Are you having that discussion? You can get venetoclax. Brad was talking about the advantages of time-limited therapy, chemotherapy. The good thing is you're off. You don't have to be on this forever. This is a more targeted approach to time-limited therapy to begin with. Has this changed how you're talking with your patients in frontline choices?
Yeah, it certainly does. I think in the right patient, again, the idea of being able to stop treatment is very, very important, and we need that with ibrutinib and venetoclax combination as well. And we have a little bit of data about that emerging, but in this setting, I think a year of therapy in many patients who don't have high-risk features is very, very reasonable. I also think the other important thing is it gives us another option in the front line. Not everybody is an appropriate candidate for a BTK inhibitor. I mean, there are people with underlying structural heart disease where you might be a little more concerned about atrial fibrillation, or people who are on anticoagulants, and in particular, there are a large number of people who are on warfarin, as an example, where we shouldn't be giving BTK inhibitors to those patients. So it gives us an option, and especially in an older patient population where they have a lot of comorbidities. So it does change the conversation. I think it's an important conversation to have with a patient around time-limited therapy, but also trying to figure out what the right agent is based on their comorbidities.
Brad, how do you think about sequencing these things? The good news is we've got many different options now. The bad news is we've got many different options, and it's hard to know what's the right order, right?
Yeah. It's a good problem to have all these good options, and it's just amazing how fast the field has emerged. Earlier I mentioned this conversation that I have with patients, FCR versus ibrutinib or BR versus ibrutinib. But honestly, that conversation completely changed as of about a month ago when we got the FDA approval of Venetoclax Obinutuzumab. And so now you have this third option, which is very attractive, targeted therapy, no chemotherapy, time limited. I just saw 52-year-old woman in clinic 2 weeks ago. She's had CLL for a few years. Her disease is getting to be very advanced. She's getting very close to the time where she needs treatment. And I was able to talk to her about this brand new option of Venetoclax Obinutuzumab. For me personally, it's a extremely attractive option, and I kind of see that being, until more data emerges, my go-to regimen, except perhaps for these very high-risk patients for whom I'm just uncomfortable, giving 1 year of therapy and then stopping, like a 17p deleted patient, for example. I mean, it's important for people to remember we're talking about progression-free survival differences by and large between all these regimens, and it's very unusual for any of these things to have an overall survival difference. So imagine that you give Venetoclax Obinutuzumab and you achieve a 3 or 4 year remission. Well, that's 2 or 3 years that your patient was able to be off all therapy. And when their disease starts to recur, you often do not have to start treatment right away. And when you do need to go to second-line treatment, you can come in with ibrutinib at that point. So even if Venetoclax Obinutuzumab ends up being a little inferior to ibrutinib as a frontline option, that isn't necessarily a reason not to use it if we're just talking about small progression-free survival differences. So I'm a big believer in giving patients a break from therapy whenever possible, and that's one of the reasons I really like this new option.
Yeah, I think it is an important option, and we briefly touched on the 3 drug regimens, but there's a lot more to learn about those and whether we can get patients into such a deep remission that prolongs progression-free and overall survival along the line. There's always been concerns, right, about since the early days of the fludarabine studies that do you use all your eggs in one setting, or do you try to sequence them? And I don't think we have the data today to know that, but it's an age-old question.